by saying we're broadcasting today from the traditional unceded territory of the Coast Salish people, including the the Tsleil-Waututh, Musqueam, and Squamish nations. Today, I'm very privileged to be able to introduce Dr. Lien Hoang. She's obviously well known to everyone here at Vancouver General Hospital and in the Vancouver Coastal Health Authority. Dr. Hoang is a gynecologic subspecialty pathologist working here at VGH and a clinical assistant professor at UBC. In the gynae oncology sphere, she's published over 100 manuscripts, authored 5 book chapters, and received greater than 50 speaker invitations at national and international conferences. I guess with this invitation, it's 51. She's a pathologist scientist, and research includes discovering novel type of uterine sarcoma, developing molecular pathology endometrial carcinoma classification scheme, overhauling the classification of system for cervical cancers, and pushing vulvar cancer into the modern molecular era. She's ranked 12 out of 400 authors worldwide by the WHO editorial committee for most impactful publications in endometrial cancer in the 5 years preceding the WHO publication, and has received several accolades in her career, including the CAP Junior Scientist Award, UBC Teaching Award, UBC Mentoring Award, VMDS Excellence in Early Career, and her work in vulvar cancer has culminated in a CCTG clinical trial, the first of its kind. As an active member of the Gynae Cancer Initiative and the Molecular and Advanced Pathology Core, MAPCore, Dr. Hoang has the honor of working with a large gynecologic cancer research network within BC that bridges scientists and clinicians, which allows translational discoveries seamless entry into the clinical sphere. Again, I've worked with Dr. Hoang for several years now, and I'm looking forward to this presentation. Lien, over to you.
Perfect. Thank you, Dr. Emo. So thank you so much for the invitation and the opportunity to speak today. I have to apologize, my computer will only recognize this sort of ancillary camera, so I'm actually not going to be looking at you all today, but that's okay. So I think this talk was actually inspired a few months ago, or requested at least by Dr. Wei Sheng from St. Paul's Hospital, who saw Dr. Andy Chirk's talk on mesothelial tumors and wanted something similar for gynecologic cancer. So what can I say? Here we are, we deliver. So thanks, Andy, for giving such an excellent presentation. So I guess I'm second to go. So for the next hour or so, I'm going to talk about the role of pathologists and reflex molecular testing in gynecologic cancers. We're going to go over some important entities that I think would benefit from IHC confirmation at first diagnosis, and we're going to go over some IHC interpretation and pitfalls. So what I really want to emphasize is that today is really a clinical practice focused presentation. So if you're an enthusiast of research work and discovery work and work into the 5th dimension of molecular space, I'm probably not going to meet your fill today. This is really a pared down practice recommendation talk, and not just any practice recommendations that apply somewhere else in the world. All of these recommendations apply here in British Columbia. So if you are a practicing pathologist in British Columbia, I hope that this will be highly relevant to you. So as many of you already know, gynecologic cancers can be broken down into endometrial or uterine cancers, into ovarian cancers, cervical cancers, and cancers of the lower genital tract, such as the vulvovaginal area. So I think most of the reflex molecular and IHC testing is actually done in endometrial cancer. So that's where we're going to spend about 80% of this presentation. So first off, our approach to endometrial cancer has drastically changed since the publication of the Cancer Genome Atlas. And I know many of you will already know, this was an NCI-led initiative that essentially used a constellation of molecular technologies to better understand more than 30 different cancer types. And that includes endometrial carcinoma back in 2013. And, it's kind of hard to believe that 12 years has passed since the initial publication. So, you probably could have finished 3 undergraduate degrees, or if you're super ambitious, maybe even 4 undergraduate degrees in the time that this has been published. But what have we learned? So we've learned that endometrial carcinoma can be stratified into 4 different molecular groups. So poly-ultra-mutated group, microsatellite unstable or hypermutated group, a copy number low group, and a copy number high group. And each of those molecular groups essentially have their own molecular characteristics as expected. They're associated with their own histologic features, clinical features, as well as prognostic features and therapeutic considerations, which we'll go through in the next little while. So when the TCGA was initially published, it was actually only done in endometrioid and serous histotypes. And we now know that the TCGA applies to more than those two histotypes. It also applies to clear cell carcinomas as well as to dedifferentiated endometrial carcinomas. So the TCGA used really, a barrage of expensive omics-based techniques, but we've learned that you can essentially get a very similar stratification of endometrial carcinomas if you use some really, simplified or pared-down technologies. So if you just use MMR and P53 IHC and polysequencing, you can essentially get the same molecular groups. So if an endometrial cancer has a pathogenic poly mutation, it's falls under that poly mutant group. If it's MMR deficient, into the MMR deficient group. If it's P53 abnormal, into a P53 abnormal group, which is essentially the correlate group to the copy number high group. And then you have this kind of other category with P53 wild type in the sort of no specific molecular profile group. So not surprisingly, this has changed the NCCN guidelines. It's also been adopted into the ESGO, ESTRO, and ESP European guidelines. And not surprisingly, it has also changed how we have approached and how we manage endometrial carcinoma here in British Columbia. So I know what you're all thinking, especially you pathologists, but it's going to be okay. We'll be able to walk through this. So if we go to the BC Cancer Management Guidelines, what does it say about endometrial cancer? So it says that MMR, P53, and ER immunohistochemistry should be performed on all endometrial cancer biopsies of all histotypes. This should be available in any pathology laboratory, and importantly, this is now considered the standard of care for all endometrial carcinomas in British Columbia. And in addition to that, POLE testing has been approved in 2022. And in the current funding scheme, it's approved for patients in whom information on POLE status would impact adjuvant treatment decisions. So who essentially qualifies for POLE testing? So essentially anybody with a new diagnosis at any stage, essentially FIGO stage 1, 2, 3 of endometrial carcinomas, and with the exception of those patients who you would not consider for adjuvant therapy at all. So essentially for those patients who are so low grade and so low stage, so with so low risk factors that you're not even going to consider chemo or radiation. So those patients would be your stage 1A, grade 1 or 2 endometrioid, P53 wild type, MMR intact, no LVI. Those patients would not qualify for POLE testing because it's not going to change management. And the other way that I like to think about it is who would you eventually send for POLE testing? So I think you would send anyone with any one risk factor where you would even think about the possibility of adjuvant chemotherapy or radiation. So that includes anyone that's stage 1B or higher, high-grade histology or grade 3 endometrioid, P53 abnormal, MMR abnormal, or someone with extensive LVI. So of course, how should you do this? So POLE testing, when the guidelines were originally rolled out, it was for hysterectomy specimens. But if you are very clever, because pathologists are really clever, if you look at those criteria, you can actually do it on endometrial biopsies because it's not going to change between a biopsy and a hysterectomy. So for example, if you run into a grade 3 endometrioid carcinoma on a biopsy, it's not normally going to change with a hysterectomy if it's P53 abnormal or MMR abnormal. If you see that on a biopsy, you can order the POLE or request POLE testing on that endometrial biopsy. And why is this important? It's important because the clinical trial eligibility for most of these patients, all of these patients, is 10 weeks. And so patients can only access some of these special drugs if they meet trial eligibility. And very often, and I'm sure you can ask other people here at the AP Molecular Lab, how many emails, and they're panicking emails from medical oncologists and radiation oncologists who are who are, really trying to meet that 10-week guideline, because it takes time from hysterectomy to referral and then to sequencing. It takes a lot of time. And so they very often don't have enough time to get that polysequencing done. So what that means is that the pathologist, who is really the first person to see this diagnosis, should be the one who's responsible for requesting POLE testing. And so we're really putting, pathologists really at the front end of patient care. So how would you actually order POLE testing or request POLE testing? Well, there is a POLE testing requisition form, and you can access this through the BC Cancer website or through the Vancouver Coastal Health website. And on that requisition itself, there actually are guidelines as to who qualifies for POLE testing. So, if you're feverishly trying to write this down, don't worry. All the guidelines are on that requisition form to make it easier for you. So we're going to go over some cases to highlight why this is important for our patients. So case one is a 68-year-old woman with postmenopausal bleeding, very common clinical scenario. She has a history of colon cancer 15 years prior. She has an endometrial biopsy that shows carcinoma, so she undergoes a hysterectomy. So this is the hysterectomy, and it's really the sort of solid growth of a very sort of poorly differentiated tumor. You can see that there are some really sort of hyperchromatic but very bizarre type atypia and a lot of lymphoplasmacytic inflammatory infiltrates in the background. And quite atypical, really bizarre looking nuclei and even some multinucleation. And of course, if you look around, there are some areas that look more glandular with a bit of sort of exfoliation or irregular luminal borders. And then you have a lot of mitotic activity in this tumor and some other areas where the glands are a little bit different. The borders are a little bit smoother, and it's sort of this compact confluence of essentially glands that are merging to become more solid. So P53 is done, and it's kind of an interesting staining pattern. You have sort of darker areas and lighter areas. It's not very homogeneous throughout the tumor. MMR is done, and that's both normal, so intact nuclear staining in PMS2 and MSH6. And this was sent for NGS, so it does show a POLE hotspot mutation as well as P53 mutations. So what is your diagnosis? So the diagnosis here is a FIGO grade 3 endometrioid carcinoma that is falls under the POLE mutant category. So very briefly, what is POLE? We talk about it essentially all the time. So POLE stands for DNA polymerase epsilase, and it's very epsilon, sorry, and it's a very special DNA polymerase because it has an exonuclease domain, which means that it is able to proofread as it goes on and synthesizes DNA, which essentially means that it has a very, very low error rate in DNA replication. So you can imagine that if you lose POLE, you end up getting these tumors with very, very high numbers of DNA mutations, which essentially leads to that ultra-mutated molecular genotype. So what do these tumors look like? So typically they look like tumors with high-grade nuclear features with lots of atypia and mitotic activity. They tend to have this sort of ambiguous histology. So if you were to look back in our VGH archive, sometimes you'll see a diagnosis of like mixed endometrioids with serous and clear cell and dedifferentiated carcinoma. And at present day, if you see a diagnosis like that, you probably think that's probably just a POLE mutant tumor that looks ambiguous. They can have bizarre tumor giant cells, tumor infiltrating lymphocytes and peritumoral lymphocytes. And interestingly, they frequently can have LVI, but they don't often have lymph node metastases. So what's really interesting about the POLE mutant group is that, in this meta-analysis, essentially these tumors do really, really well. So regardless of whether they have received adjuvant therapy or not, the number of adverse events being is really, really low. So what does that mean for treatment? So in British Columbia, if you were to diagnose this as a FIGO grade 3 endometrioid carcinoma, POLE mutant, this patient is probably just going to undergo observation. And let's say you didn't end up doing poly sequencing in this case. This would be called a, endometrioid carcinoma grade 3 with a p53 abnormality. And this patient would end up getting 6 cycles of adjuvant chemotherapy. So really starkly different depending on that poly status. So I know that there are inclusion criteria for when you're doing poly testing, but there are also some pathology tips or pearls that you can take away. So if you encounter a young woman that you think you're going to call a serous carcinoma, so for example, if you look at this case, there's a lot of atypia, it looks quite ugly, and you do a p53, and it looks like really a missense mutational pattern, you can easily call that a serous carcinoma. But in a young woman, you should really think about a poly mutation, which is what occurred in this case. And we know that in patients that have poly mutations, even if they have concurrent p53 mutations, it doesn't confer a worse prognosis. And so we still cluster those tumors into that poly mutant category as opposed to moving them into the p53 abnormal category. And the other hints to when a poly mutation is present is if you see odd or subclonal MMR staining patterns or subclonal p53 IHC patterns. So you can see that in the image on the right, and same thing in the index case that I showed you, with this sort of funny p53 pattern. So if you see that on a biopsy, you should be even more motivated to send that for poly sequencing because your pretest probability is going to be a lot higher. So that would motivate you more. Okay, so that's poly. Case number 2. This is a 55-year-old with abnormal uterine bleeding. Biopsy is positive for carcinoma. She undergoes hysterectomy. So sort of intermediate power look at what we're looking at, sort of very homogeneous looking appearance with these sort of tall columnar cells that are starting to merge and become a little bit more confluent. And like, I always tell the residents, when you're trying to histotype a tumor, think about you driving around in whatever luxury vehicle of your choice, Toyota Prius for many special pathologists out there. You can drive your car and it's nice and smooth, and you think about this histotype. And if it's not smooth, you think about other different histotypes of endometrial cancer. So MMR testing was done. So MLH1 and PMS2 are diffusely lost. And the MSH6 is interesting. So it's lost, but only lost in the sort of subclonal zone or focal loss and not throughout the tumor. So this was sent for MLH1 promoter hypermethylation testing. It did come back positive for MLH1 promoter hypermethylation. This was also sent for NGS, so there was no p53 mutation, and there's no poly mutation in this case. Okay, so your diagnosis here is a low grade or FIGO grade 1 endometrioid carcinoma that is MMR deficient or MMRD. So why does MMRD matter in endometrial carcinoma? So it matters for a variety of reasons. And I think most of us, the first thing that we think about is hereditary cancer referral and the possibility of Lynch syndrome. But, it matters in a lot of other facets as well. So MMR deficient tumors, they're more likely to have LVI. So the surgeons are more likely to consider lymph node dissection. And in one of the most recent or more recent PORTEC-3 trials, these tumors are not really responsive to chemotherapy. So adding chemotherapy on top of radiation doesn't help. And so for these patients, they're more likely to get isolated radiation therapy without chemotherapy. They can be considered for immune checkpoint inhibitors, and disease classification is really helpful. So I find that particularly for dedifferentiated endometrial carcinomas, which have loss of MMR in about 50% of cases, MMR is really, really helpful because often in undifferentiated tumors, they can have sort of aberrant expression of a lot of different immunomarkers, but MMR is really, really helpful and, really pinning it down to being something that's probably an endometrial primary and with 50% probability of it being lost. So how are these MMRDs treated differently? So I mentioned this in the preceding slide. So these tumors are not really sensitive to chemotherapy, so they're more likely just to get adjuvant radiation therapy and maybe even the possibility of an immune checkpoint inhibitor. So what do these tumors look like? So typically they have, tumor infiltrating lymphocytes, peritumoral lymphocytes. They tend to have mouth pattern invasion or microcystic elongated and fragmented pattern of invasion. Again, they're more likely to have LVI and lymph node metastasis. Again, they can look really funny because of their hypermutated status. They can have morphologic heterogeneity or ambiguity. And sometimes they have mucinous differentiation. They're more often seen in dedifferentiated tumors, and often they look high grade. So MOR interpretation, I am not going to go into a lot of detail, but essentially what I wanted to emphasize is really the need for hereditary cancer referral. So, if you have an abnormality in PMS2 or MSH2 or MSH6, essentially that's almost always going to be Lynch syndrome, and so hereditary cancer program referral is needed. And then for MLH1, it's a little bit different. So, 80% of patients that have loss of MLH1 is due to just MLH promoter hypermethylation, and so those cases are just sporadic. And then about 20% of those showing MLH1 loss are not due to MLH1 promoter hypermethylation, and they should be referred to the hereditary cancer program. So I guess the question for you as a pathologist is, well, who does the referral? So, not being patient-facing physicians, it is actually the submitting gynecologist or surgeon who is responsible for that referral to the BC Hereditary Cancer Program. And then the other thing that's sort of in the works is, who orders the MLH1 promoter hypermethylation testing? So in our current system, this is ordered by the Hereditary Cancer Program, but I will say that it's a bit of an odd system that it shouldn't really matter who orders the test. So we are trying to work with the HCP currently to allow pathologists to also order that test. So, you might hear back in the next few months from us to try to get that changed. And the other thing about MMR interpretation, if this lands on your desk, is, MMR interpretation has changed drastically since it was initially described. And certainly when I was a resident a long time ago, and I won't tell you when because, it's a little bit embarrassing for me. So, again, I would have finished many undergraduate degrees when I was a resident, since I've been a resident. But, when I was a resident, I was taught that any staining is normal and don't worry about it. And then that's not true. So, if you have sort of weak staining in the tumor cells, and you notice that they are substantially weaker than your internal control, being inflammation or stromal cells, that's abnormal, and you should call that abnormal. And the other is, regional loss or subclonal loss is also abnormal, and you should call that an abnormal MMR stain. The other questions that come up as practicing pathologists is, should you do MMR and hyperplasia? And I would say that that's quite an exceptional scenario. And the only times that you would think about really doing that is if the clinician is, really wanting to do fertility sparing therapy, like prolonged trial of progesterone, but they're worried about the possibility of Lynch syndrome. So you could do MMR in the hyperplasia, but I would caution you that MMR is only lost in adjacent hyperplasia in about 50% of cases. So if you are to do the MMR, just make sure that you put in a comment in your pathology report that MMR should be repeated if ever this patient develops endometrioid carcinoma, because you certainly do not want to miss out on that clinical information, prognostic information, treatment information, and the possibility for immune checkpoint inhibitors. The other question that often comes up is, should you do MMR on synchronous tumors and should you do it on recurrent disease? And this is kind of interesting because there is sort of this biologic phenomenon or question, and then there's sort of like the realities of practice. So, biologically, if you see, for example, this metastatic, or recurrent abdominal mass that has MMR deficiency, and the endometrial tumor was originally called MMR normal, most of the time, the discrepancy is actually due to subclonal loss that was not picked up, poor interpretation from, poor ischemic times or ischemia, or, loss or subclonal loss that was not seen on the current block, but in another block. So biologically, the switch is actually pretty rare. But the reality is there is still a discrepancy, in like 10 to 30% of cases, depending on what you're reading in the literature. So I would say that, if your clinician is asking for recurrent or metastatic disease, that would be reasonable to repeat that MMR in that particular scenario. Okay, so case number 3. So this is a patient with chronic pelvic pain, and she has known endometriosis. She's actually considering having a hysterectomy just for her chronic pelvic pain, but they appropriately do a biopsy, and it shows a typical hyperplasia. So she goes and has her hysterectomy anyway. But here is a low-powered look at that uterus. And you can actually see those areas of, inactive sort of atrophic looking glands, and those adjacent glands are a bit more columnar in shape. But the atypia is still pretty low, moderate, and not a lot of mitotic activity. PMS2 and MSH6 are done. ER is done, it's strongly positive, and P53 is done, and it's also quite positive, and it actually looks like a missense overexpression mutational pattern. So NGS was done. So this does confirm a P53 missense mutation. There's no poly mutation. So the diagnosis here is a FIGO grade 1 endometrial carcinoma that is P53 abnormal. So what do we know about the P53 abnormal group? So again, if you go back to the BC cancer treatment guidelines, these patients, if there's any form of myoinvasion, is going to be treated with 6 cycles of adjuvant chemotherapy. And in some of the clinical trials, they can also get PARP inhibitors such as olaparib. So P53 abnormal endometrial carcinomas, I think most of you know quite well. So they're typically serous carcinomas. They have high-grade nuclear atypia, destructive growth, LVI. 50% of these patients will recur metastasize. And in terms of P53 interpretation, again, I think most of you are really familiar with the scheme. So there's 4 different patterns, sort of a wild type pattern, heterogeneous staining, and then 3 mutational patterns, overexpressed, null or absent, and a cytoplasmic aberrant pattern. So sort of the question that comes up is, should P53 change your diagnosis? So if you think about the index case that I showed you, it's a low-grade endometrial carcinoma. It has a P53 abnormality, but I think it would be really difficult for you to call it a serous carcinoma because it looks like a low-grade endometrioid. And we know that about 5% of low-grade endometrioid carcinomas can have P53 abnormalities. It does confer an adverse prognosis compared to those that don't have a P53 abnormality, and this is also applicable even in low-stage disease. So similar sort of questions, like what if you have a clear cell carcinoma with a P53 abnormality? Can I just call it a serous carcinoma or a serous-like carcinoma and just forget that whole histotyping ever existed? And if you're one of my colleagues here at BGH, I'll probably have flip-flopped on this topic many times. But I think thinking about it, with those truncal abnormalities being quite different in clear cell carcinomas, I think if it looks like a clear cell carcinoma, you should probably still call it a clear cell carcinoma with a P53 abnormality, though not everyone would agree with and what about subclonal P53 staining? So this has come up, what is relevant or what is a cutoff that should make you worry? So, there's been a recent publication that shows that if you have an aberrant mutational pattern in 10% or more of the tumor, then that confers an adverse prognosis. And if it's less than 10%, you don't really have to worry about it. But just a reminder that if you do see subclonal P53 staining, think about poly mutations, think about sending that for poly sequencing, and think about also doing MMR immunohistochemistry. But of course, you would do it anyway, right? Because we are in a reflex testing system in British Columbia. And the other thing that comes up is, why do you need to do poly sequencing for P53 abnormal endometrial carcinomas? And arguably, this is maybe a little bit of overkill, but we have seen cases like poly mutant cases that look very serious, and they can even have a P53 IHC pattern that looks quite mutant, but those actually will do very, very well. So currently, we still do poly testing in the presence of a P53 abnormality. And you can see from the survival curve, polymutated tumors with P53 abnormalities still do quite well in comparison to those tumors that don't have polymutations and only have a P53 abnormality. So something else that you might come across increasingly in the last year or two with the GOG and Destiny trials is that 20% of P53 abnormal tumors, so mostly serous, but some high-grade endometrioids, can have HER2 amplification, and they would benefit from trastuzumab added on top of their chemotherapy regimen. So if you are asked to do this, we don't do this reflexively, but if you are asked to do this, you should refer to the CIP guidelines as to HER2 interpretation. It is a bit of a blend of like gastric breast, so it's slightly unique, but it's sort of a blend of the both. And the other thing is to caution you that HER2 expression is a lot more heterogeneous in endometrial cancers compared to in breast carcinomas, so you might get some discrepancies between biopsies and hysterectomies. Okay, moving along. So case number 4. So a young 32-year-old with menorrhagia. She has a normal BMI, no family history of malignancy, and 9 months after her initial endometrial biopsy, the CT scan shows that she has multiple pulmonary nodules. So here's her endometrial biopsy. So a lot of tissue to look at. Kind of glandular, maybe solid or crowded. And you can see most of this is sort of columnar-shaped glands, pretty smooth luminal borders, some nucleus stratification, and some other areas maybe more cuboidal, maybe a little bit papillary, maybe a little bit sclerosis, kind of hard to tell. And some other areas that these glands are a little bit more sort of crowded, tubular looking. So MMR was done on the biopsy. It is normal. P53 was done on the biopsy, and it is normal or wild type. So she gets a diagnosis of a low-grade, FIGO grade 2 endometrial carcinoma. P53 is wild type, MMR is normal, and she goes on to have a hysterectomy. So here's the hysterectomy. And you can see, what you saw on the biopsy, but in addition, there are some areas that are a little bit more solid or confluent. And these areas are kind of interesting because they're more solid, but those cells are still, the nuclei is still pretty small. They don't have that sort of severe atypia and mitotic activity you would expect for a FIGO grade 3 endometrial carcinoma. And of course, during reflex biomarker testing, ER was not done on the biopsy, so you do it on the hysterectomy, and ER is completely negative, which is really surprising, and conjures a differential diagnosis on its own. So GATA3 and TTF were done, and they were both positive. And, sometimes with the eye of imagination, they can be positive in an inverse staining pattern, but, this is not really a consistent finding. Lucky if you have it, and if you don't think much about it. So the diagnosis here is a mesonephric-like carcinoma of the endometrium. So this last group of endometrial carcinomas is really quite a mixed bag. We call it the node-specific molecular profile group, but they can get chemotherapy, radiation, they can get conservative therapy, hormonal therapy. So they really are kind of a mixed bag. But increasingly what we know about this large category of copy number low or NSNP is that most of them are indolent, but 20% of them will recur. And if you actually pull out those cases that are ER negative, those account for really the vast majority of adverse events in the node-specific molecular profile group. So ER is actually really, really helpful because you're able to capture those aggressive types of node-specific molecular profile group. And I think if you are having a bad day, so if your baby is up at 4 a.m. or like your dog wakes up and decides to throw up on the floor, or like the US decides to put tariffs on Canada, you should do the ER because it might make your day a bit better, because ER, I think, can save you a lot of the times because it will help you pick up some of those aggressive histotypes that you might have missed. So, mesonephric-like carcinomas or clear cell carcinomas, dedifferentiated carcinomas, and even endocervical adenocarcinomas that look like uterine tumors. If you do the ER, it can really, really help you. So I would certainly suggest doing it on all of your endometrial biopsies if you're not sold already. And there's even some talk that, we should do this as standard to separate out our NP groups into your ER positive, good prognosis group, and ER negative, bad prognosis group. And, just a reminder that, this is recommended as a standard of care in British Columbia. And it also affects whether or not patients will be referred to gynecologic oncology subspecialists. So the community gynecologists have a list essentially of if you see this on your biopsy, they need to get referred to gynecologic oncology for further workup. And that list includes ER negativity. So I think for all of those reasons, ER is a really good marker to throw on your endometrial biopsies. So that's all on endometrial cancers. We're going to move to ovarian cancers. So next case. So this is a 71-year-old with peritoneal carcinomatosis with debulking surgery is performed. Again, a very, very classic history. So this is the ovarian tumor. It kind of has a really interesting growth pattern with these sort of broad papillary growth, sort of lined with these really thick bands of tumor with quite a bit of cytologic atypia, moderate to severe, lots of necrosis, and a bit of mitotic activity. And WT1 is positive, ER is positive, and P53 is abnormal. So she is found to have a BRCA1 mutation. She is given chemotherapy and a maintenance PARP inhibitor, which is olaparib. So the diagnosis here is, not surprising, an ovarian high-grade serous carcinoma with a BRCA1 mutation. So this is just a reminder that if you are thinking about making a diagnosis of transitional cell carcinoma, it's almost non-existent nowadays. It really is just a variant of high-grade serous carcinomas, and that falls under this set pattern. So solid, pseudoendometrioid, transitional pattern or set pattern should really make you think about a BRCA mutant high-grade serous carcinoma or one with HRD or homologous recombination repair deficiency, because they're more likely to harbor these abnormalities if they show these histologic features. But that brings us back to why we're here, which is to talk about reflex molecular testing. So BRCA1 and 2 tumor testing is now the standard of care for all high-grade epithelial ovarian carcinomas. But specifically in British Columbia, those with a diagnosis of high-grade serous carcinoma with their BRCA1 or 2 mutation, it qualifies for PARP inhibitor maintenance therapy. So that really motivates, again, another shift for putting pathologists, up to really the front row in patient care. So if you diagnose a new diagnosis of extrauterine high-grade serous carcinoma, then you are responsible for sending this for BRCA1 and 2 testing. And how would you do that? So this is actually done through BC Cancer CGL. So you go onto their website, you find the solid tumor molecular form, fill out the form, send out a tissue block. And so you just have to remember, FFPE with 20% tumor content is the minimum required. Cytology specimens are also acceptable if they are in an FFPE block. So, those in other fixatives are not acceptable. And post-treatment specimens, those with neoadjuvant chemotherapy are also acceptable. So the other thing to do is, put this in your pathology report that you sent this out for BRCA testing, and also put in your pathology report if you considered it, but there just wasn't enough material to send for testing. And so whoever is the subsequent pathologist in this patient's clinical care pathway, they can then order that BRCA mutation testing. So there's other reflex testing in ovarian cancers, and this includes MMR in endometrioid and in clear cell carcinomas. So this only applies to these two histotypes as they're related to endometriosis. Mucinous doesn't apply. Low-grade serous borderline tumors don't apply. Okay, and then I'm just going to spend no time in cervical cancer because there isn't really a lot of reflex molecular testing aside from PD-L1, which the vast majority of British Columbians don't do. So, that does not really a province-wide relevance. So we're going to go to vulvovaginal tumors. So case 6. So this is a 62-year-old woman with soreness of the right inner labia. She has a 4-centimeter deep-seated lesion. Biopsy is positive for cancer, so she undergoes a radical vulvectomy and a lymph node dissection. So I don't think the diagnosis is difficult here. I think, you can kind of see this infiltrating, very pink tumor with some keratin production. And of course, as the astute and responsible pathologist that you are, you look around for an in situ lesion and you think this is probably the in situ lesion in this particular case. It's very, very pink, almost hyper pink with some nuclear atypia. And in other areas as well, a very, very pink dyskeratotic area. And again, you are responsible. So you do the P16 immunohistochemistry. It's strongly diffusely positive, even in that in situ looking area. And P53 is quite interesting because in that in situ area, you got strong staining in the peribasal layers, but you got no staining or absent staining in the basal area, which is a staining pattern that is very unique to HPV infection, high-risk HPV infection. So your diagnosis here, invasive squamous cell carcinoma that is HPV associated. So the message here is that you should substratify your squamous cell carcinomas. And this is recommended by the WHO, by the ICCR, by the College of American Pathologists, that essentially this should be stratified into HPV associated and HPV independent types. And how are you going to do that? So not everyone's going to have HPV testing at their disposal, but that's okay because P16 is actually a really sensitive and reliable marker in this context. So if this is strongly positive, nuclear and cytoplasmic, strong and diffuse, this is a positive P16 and a surrogate marker for the presence of high-risk HPV. And then if it's patchy or negative, then this is not related to HPV. And of course, there's growing evidence that P53 can also separate HPV independent groups into a really aggressive group and an intermediate group. So we also do P53 on our vulvar squamous cell carcinomas as well. So it's recommended that you do both P16 and P53. And if you're looking for a P53 mutant pattern, they're basal overexpression, parabasal diffuse overexpression, absent or cytoplasmic. So fairly similar to interpretation and epithelial tumors, but a little bit of terminal differentiation. So a little bit of a different interpretation. But even though this isn't going to change immediately how these vulvar squamous cell carcinomas are treated, the clinicians will certainly know that P53 mutant HPV independents are more aggressive, and they are more likely to consider, more aggressive margin clearance and lymph node dissection. But I've noticed that since people have been thinking about P16 and P53, they're pretty much doing P16 and P53 on everything, which is great, but you also kind of have to back the train up. Not everything is an SCC in the vulva. So just a reminder that, if you look at this tumor that looks quite infiltrative with these really large, broad nests and a lot of desmoplastic reaction, and of course, a little bit of peripheral palisading. And if you do P53 in this context, it's actually really, really strong and it could worry you. But the diagnosis here is just a basal cell carcinoma. So rare in the vulva, but not everything is an SCC. This is another lesion that is, has these really broad pushing borders. But if you look really carefully, there's probably some viral cytopathic effect. Low risk HPV is positive. So this is just a condyloma, or if you're special, a giant condyloma, Buschke-Lowenstein. So not an SCC. And this is another case with these infiltrative, irregular looking nests with a lot of inflammation in the background. And those nests can look really worrisome, but this is a spirochete stain and it's very, very positive. So this is syphilis with pseudoepitheliomatous hyperplasia, again, not an SCC. And just a few worthy mentions, that I've seen sort of in the years of clinical practice. One is the classification of vulvar intraepithelial neoplasia. So just a reminder that these are separated into HPV-associated VIN and HPV-independent VIN. This is very similar to what we do for invasive squamous cell carcinomas. And then under HPV-associated VIN, there's L-cell and H-cell, due to low risk and high risk HPV respectively. And then you have your HPV independent VINs called DVIN or VAVIN, but don't worry about the terminology. You can just probably stratify them by P53 mutant or P53 wild type, and that is totally acceptable. But I just wanted to emphasize that I've seen a lot of people use the term HSIL for their biopsies, even when it's HPV independent. So just a reminder that the term high-grade squamous intraepithelial lesion that was really taken from Bethesda and then taken by the last criteria group, it only applies if it's HPV associated. So if it's not HPV associated, don't use the term HSIL. And then say the same for DVIN. Like you would never use the term DVIN to describe like VAN3 or CAN3. Like it's completely different. So just make sure you use the right terminology in these particular cases. There's a bit of controversy as to, do you need IHC to confirm your first diagnosis of VIN? And the reason why this comes up is because sometimes the morphology can be deceiving, and in about 5 to 25% of cases, you might be deceived. So, for example, if you look at this case of DVIN, that's really, really pink. HSIL with superimposed lichen simplex chronicus can also look really, really pink, and it can also look like DVIN. And if you look at this case of HSIL, really blue, poorly differentiated, you can also have the morphologic mimic, which is basaloid DVIN. So there are some people who would recommend that, for a first-time diagnosis, to do a P16 immunohistochemistry just to make sure that that patient goes down the right clinical treatment pathway. The other worthy mention, again, this just comes from being in practice for so many years, is the diagnosis of extramammary Paget disease. And people have different recommendations of how far to go to make sure that this is not due to secondary extension from the bladder or for the colorectal region or anal region. I'm not sure what that would be. But I do think that you should have at least one immunohistochemical stain to make sure that you're actually looking at extramammary Paget disease. Generally, CK7 is really good. And the reason why I've seen that is I've seen more often than not cases of extramammary Paget disease, confused with melanoma in situ and vice versa. And they have really quite different treatment. Melanoma in situ, you're looking for a 5 millimeter clearance. Extramammary Paget disease, they don't actually want surgical margin clearance. And sometimes you have, you're lucky and you can see a bit of an eyeliner sign that you see in extramammary Paget disease. And as I mentioned in other talks, I don't wear eyeliner, but, I'm good at many things. I'm terrible at wearing eyeliner, so I know my limitations in life. But regardless of whether you wear eyeliner, I think that you can still kind of see what I'm talking about. But you're not always lucky to have these histologic features. So I think doing just one immunohistochemical stain, especially for a first-time diagnosis, can be extremely helpful. So I think that is the end of my talk. And thank you so much for listening.
Lien, thank you very much. That was an excellent, such a comprehensive review, and certainly very informative for everyone here. I guess we'll open it up if anyone's got any questions for Dr. Hoang. I've got a couple, but I'll wait. The only thing I was worried about, Lien, was the fact that you didn't reference the seminal paper on extramammary Paget disease.
I thought that would be too overwhelming for our audience members to be in the presence of such greatness. So I thought I would leave that out of this talk.
Okay, fair enough. Questions for Dr. Hoang? Oh, everyone's they're too intimidated, Lien.
They're eating lunch. They're happily eating free lunch, which is understandable.
I have a quick question for you, Lien. So given that there's P53 abnormalities in endometrioid type, endometrial carcinoma, clear cell, etc., don't some suggest just calling it P53 abnormal? Maybe Dr. Coble from Calgary?
Yes, he does. So yeah, as I mentioned, not everyone will agree. There's different opinions, and maybe we shouldn't be struggling with histotype diagnosis. If it's P53 abnormal, who cares, right? They're gonna do poorly, and we can just call them P53 abnormal. And I kind of flip-flop on this issue, but again, I think if it's a clear cell carcinoma, if we think about our future, that there might be actually clear cell carcinoma sort of specific treatments down the road. So instead of putting them in one category, we can try to keep them separate, just in case more specific histotype treatments are developed. So I think if you can subcategorize, do it, and if you can't, P53 abnormal is probably acceptable.
Fair enough. I see Gao. Did you have a question or comment, Gao?
I just want to thank you for actually identifying Lien and get her to give the talk. And this is a great, great talk. And in the future, we need this kind of talks for standardization in terms of our practice. Make sure that everyone is up to standard. And I'm very impressed that every single report they put in there that with a clear diagnosis and followed by relevant biomarkers or genomic abnormalities that's relevant for clinical care. So this probably should be the standard of practice across for all different cancers or any other diseases. With the diagnosis, then what is relevant, genetic, genomic, or biomarker abnormalities. Yeah, I saw Diana is raising her hand. Diana, please. Yeah.
Hi. Excellent talk, Lien. Excellent. A tour de force. I have two practical questions. When you guys report the polymutations, do you specify the pathogenic versus non-pathogenic? And also, could you maybe talk a little bit about the association of the pathogenic poly-E, maybe with MMR deficient? So that's one. And my second question, I'm not sure in our patient population in BC if trastuzumab is still used and whether or not our patients only have access to trastuzumab deruxtecan, because if that's the case, the pathologist would absolutely need to know which one of the two treatments the gynecologist has in mind, as the interpretation is completely different. And one of the downside algorithm that we have to do is for trastuzumab deruxtecan to remember not to fish.
Yeah,
we learned that the hard way.
Yeah, absolutely. No, those are all really, really good comments. So, number one, I'm glad Dr. Gao has picked up on the clinical relevance, and I hope that the audience also picked up on that. Though we're not doing these biomarkers because we've got tons of time on our hands, and we're just, just making work for ourselves. So this is really clinically relevant. And Dr. Ionescu has brought up two really good points as well. So non-pathogenic mutations like SNVs or synonymous mutations, we don't report in our current pipeline. So they're actually not put in into the pathology report. So we only put it in if there's evidence that it is pathogenic. And then I guess the second question is about the upcoming ADCs. So the trastuzumab, the ADC is growing. I think it's growing not just for endometrial cancers, but also for gastric cancers, etc., as through the Destiny trials. So right now we don't do HER2 testing, reflexively, and I think that's partly what you're talking about, access. Maybe one day there'll be more access, but right now, it's really the oncologist that will email you and ask you to do the test. And then, of course, you just have to follow the CAP guidelines as to how that's positive or not. But sorry, I see you're shaking your head.
No, you know what I want? So I really am uncertain if in BC is trastuzumab alone, which has the criteria, the CAP interpretation criteria that you showed in your presentation, or trastuzumab deruxtecan as per Destiny 06, which has completely different testing criteria because the entire trial for tumor agnostic used gastric criteria without HER2 amplification. So for us, even if you get an email or a request from a clinician in endometrial cancer, you need to know what is he going to use it for, because the criteria is so different. But I was under the impression that trastuzumab is no longer an option, but I may be wrong.
Yeah. So I've gotten a few requests from oncologists considering the use of trastuzumab. So I think probably through compassionate release or some sort of exceptional avenue, they can request for trastuzumab. So I think with the oncologist asking for it, they can probably get it somehow. And the second point is a really good point, because the Destiny trial did use gastric criteria. So I don't know if the ADC is actually available and which criteria in that particular setting. So probably the best advice for the audience would be to ask the oncologists what they are using it for. And if this becomes a wider issue, then we'll all have to sit down and come with some agreement as to how we will manage and triage and report these cases.
The testing is also for cervical cancer, as per Destiny 06. It's endometrium and cervix. Excellent talk. Thank you. Thank you.
No, thanks. Really good questions you brought up. Yeah, certainly things that we'll face down the road with all of these trials coming up, for sure.
And Lynn, I have one more question, and it was a discussion we had about a year ago or 2 years ago with respect to what is the difference, or is there a difference between condyloma acuminatum and LSIL? Or are they by definition the same?
Depends who you ask. So,
I know.
So it depends if you ask a gynae or a derm, I think. As for the last criteria, condylomas are LSILs. So you're supposed to report them as LSILs bracket condyloma. But not everyone agrees with that. And that's because condylomas are essentially benign. They have no risk of recurrence or transformation. And then LSIL does, even, albeit being a very, very, very small risk. So some people don't believe that they should be essentially conglomerated under one diagnostic heading. But no consensus, I would say. You could probably appropriately use both terms, perhaps in parentheses. But yeah.
Okay.
Yeah.
Perfect.
Can I say something else? Can I say something else that was very endearing when I heard you presenting? Driving the car on the endometrial cancer for the diagnosis. I remember that, and I'm wondering if that comes from Blake, a trunk mutation. Many of us having been trained by Dr. Blake Jilks. I don't know, but I remember that all the time, driving the car as you come to the diagnosis of endometrial carcinoma.
I love that sentence too. Yeah.
I thought it was smart and I made it up myself, but I totally could be wrong.
I don't know where I remember it from. I really don't know, but I do. Thank you.
Well, Lynn, again, excellent, very comprehensive, very clear, concise. Really enjoyed the talk and excellent handling of the questions. I think this is the new gold standard for the delivery of these types of sessions. If anyone's interested or has suggestions, I would actually be looking for one on breast carcinoma. I think that could also benefit from this type of a presentation. You can reach out to me. Everyone have a great afternoon, have a great weekend, and talk to you next time. Bye-bye.